Madam Chair. Are
Yes,
you ready
I'm
to begin?
ready to begin? Yes.
Please provide a 5-second countdown.
5, 4, 3, 2, 1. Good morning. A quorum being present, I call this hearing to order. Without objection, the chair is authorized to declare a recess at any time. We have a number of members participating remotely today. Before we proceed, I would like to go over some of our items for our members participating remotely. First, if you are experiencing connectivity issues, please make sure that you or your staff contact our designated technical support so those issues can be resolved immediately. Members participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee and subcommittee policy that members participating remotely will remain muted when not recognized, just like turning off your microphone during an in-person hearing. This is out of courtesy to all members on the committee and so that background noise does not interfere with any other member being recognized to speak. When you are recognized, you will need to unmute your microphone and pause for 2 to 3 seconds before speaking to ensure everything you say is captured on the live stream. If you wish to be recognized, please unmute your microphone and ask to be recognized. If you wish to have a document inserted in the record, please ask for unanimous consent and have your staff email the document to veteransaffairs.hearings@mail.house.gov. It will be uploaded to the committee document repository. Please keep in mind that you will need to refresh the repository page as it does not update automatically. Without objection, members will be recognized in order of committee seniority for questioning witnesses today. This will make it easier for me to ensure all members participating are recognized and have the opportunity to speak. Does any member have a question about the conduct of this hearing with members participating remotely? I now recognize myself for an opening statement. As we approach the 19th consecutive year of United States military operations in the Middle East, our country and this committee continue to build a better understanding of the long-term health effects the service has placed on the men and women in uniform who serve there. Beyond the immediate threat to their lives inherent in combat operations, their new environment was filled with dangers like dust, debris, brought about by large sandstorms, and often exacerbated by military and regional burn pits filled with black plumes of smoke. These plumes would regularly close in on their sleeping quarters on base or around them as they went about their jobs every day. Whether they were fixing aircraft on a flight line, back in the Command Operations Center providing intelligence reporting, or clearing buildings, these burn pits indiscriminately exposed our service members to many unknown hazards. On my own staff, I have a Marine veteran that spent the first month of his deployment driving a large dump truck-styled military vehicle across a large base in the Al-Anbar province of western Iraq. And he's explained to me that every day during this assignment, he and his cohort set out to pick up large Connex boxes filled with unknown materials to be driven to the burn pits on base. They average between 8 and 10 Connex boxes per day, each one filled and brought to a burn pit for dumping. Every time they dumped a full container, dust would fill the air as the items dropped more than 10 feet into the ground. They were not provided masks, and seldom did they wear gloves. And just a few hours after filling these pits, they and their cohorts would see black smoke hover over the base. They would also perform on-base fuel runs, again exposing themselves to the toxic fumes from JP-5 jet fuel without masks or gloves to protect their skin from irritation. This is just one story from one person, but it cannot be stressed enough that scores of thousands of our service members were exposed to these airborne hazards. Many of our service members knew that being so close to these burn pits was hazardous, yet we continued to burn them until 2011. Now many people are saying this issue is the Agent Orange of the post-9/11 generation, and stories from across the country and world seem to agree. We are now seeing young, healthy veterans in their 20s and 30s suddenly debilitated by cancers they would not reasonably contract unless they were heavily smokers or deep into old age. We know this, and yet we still see people who don't receive disability benefits. If you're too sick to work, you rely on these disability benefits to pay the bills. Not only that, Service Connection is often the gateway to VA health care. I don't want to see veterans with a mountain of private medical bills because they can't get their treatment. in the VA. Today, I want to hear from VA what we can do to serve these veterans. I understand it's difficult to create a one-size-fits-all solution for toxic exposure when science is lagging behind. But what we cannot do is continue to delay and deny while veterans suffer with service-related diseases. Earlier this month, the National Academies released their latest report. Unfortunately, the report couldn't say for certain which diseases are linked to burn pit exposure, but they did reach some conclusions about symptoms. They found that chronic persistent cough, shortness of breath, and wheezing were associated with airborne hazard exposure. What I want to understand is what we can do today. The National Academies has recommended a number of next steps we can take to move the ball forward. I thank the National Academies for their research and for being here today, and I look forward to hearing your thoughts on how to prioritize future research and what short and long-term studies might yield. I also want to hear from VA how we can bring more burn pit exposed veterans into the VA, whether there are changes to law in Congress that we need to enact or policy changes that VA can provide. I don't want to see veterans turned away from the department. By the end of this hearing, it is imperative that we leave here with a better understanding of where VA currently stands in addressing disability assistance for our veterans who have been exposed to airborne hazards in this theater of operation, and the role that Congress can play. I will now turn it over to Ranking Member Bost for his opening comments. Mr. Bost, you're recognized for 5 minutes.
Thank you, Chair Luria. And thank you for being here to discuss a very important topic impacting veterans and their families. DOD used burn pits to dispose of waste near military bases when alternative waste management services were not available. Unfortunately, some of the service members have reported that they began to experience respiratory problems such as shortness of breath and asthma while serving in the Southwest Asia theater of operation as well as Afghanistan. These veterans believe that their health conditions are caused by exposure to burn pits and other airborne hazards while deployed overseas. As a result of these concerns, I've heard requests from members and veterans to create burn pit presumption of exposure. In the past, Congress has extended a presumption in situations where it may be difficult for veterans to prove exposure because scientific data was incomplete or unavailable. The most notable being the enactment of the Blue Water Navy Veterans Act of 2019. But unlike the need to extend a presumption to Blue Water Navy veterans, where too much time has passed to rely on scientific reporting to support and to determine exposure, burn pits were used within the last decade, and the data necessary to determine how to establish a burn pit presumption may still be available. Several of my colleagues in the House and Senate, many of whom are present here today, have introduced proposals that would streamline the processing of burn pit-related claims. For example, H.R. 4086, which was introduced by Representative Bilirakis, would require VA to determine whether to extend a presumption of exposure for conditions that are linked to burn pits exposures in response to the NAS's studies. Senator Tillis and Representative Ruiz are also exploring the individual approaches for legislative framework to create a presumption of exposure to burn pits and other toxic exposures. Similarly, Chair Luria and Senator Sullivan are working on their concepts for legislation that would lower the VA standard for ordering disability exams for burn pit-related claims. I know that the DAV has been a strong advocate for the concessions of exposure concept for exam purposes, and I'm looking forward to their related testimony today. All of these bills are intended to ensure that veterans who are exposed to burn pits receive their earned care and benefits. That said, I am hoping that any legislation we move that would establish a burn pit presumption is supported by science. Therefore, I'm looking forward to discussions with the NAS and in conclusions in their latest report on the long-term health effects of airborne hazards in Southwest Asia theater. As you may know, the NAS reviewed 27 respiratory conditions, including cancer and asthma. However, all of those conditions, the NAS ultimately only found limited or suggestive evidence of the associated between the exposure to burn pits and respiratory symptoms, such as shortness of breath. For all other concerns, NAS could not find an association to burn pit exposure due to limitations in their available science. This is why I was pleased that the NAS offered multiple recommendations for additional research that the VA and the scientific community can conduct to help us better understand the conditions that may be caused by exposure to the burn pits. Therefore, I am interested in discussing whether the VA intends to expand its studies to implement the NAS's recommendations. Although the NAS report brings us one step closer to getting these veterans the answers they deserve, there's always more that we can do. I'm hoping that this hearing sheds light on the best path forward on these issues for the burn pit exposure veterans. I also want to let the committee know that I will be needing to step out in order to introduce a constituent of mine who is testifying in another hearing around this place. Things kind of overlap, but I will return very, very quickly. And again, I'm wanting to thank everyone for being here, and I look forward to this morning's testimony. And with that, I yield back.
Thank you, Mr. Boss. We have joining us this morning the chairman of the full committee, Chairman Takano. I'd like to recognize you for 5 minutes for your opening statement.
Thank you, Chairwoman Luria, and thank you for holding this hearing on this very important topic. At least 2 generations of veterans have served in the Southwest Asia theater since the beginning of the wars in Iraq and Afghanistan. And even during this pandemic, new recruits graduate boot camp, their fresh faces, serving as a reminder that young men and women, some not even born during the September 11 attacks, are willing to risk their lives for this country, for this country's physical preservation and its ideals, and still some may be asked to go to this very theater of war. To be clear, today's hearing is not only about what we will do for yesterday's warfighter and today's veteran. Today, our oversight focuses on the airborne toxic hazards that pervaded the Southwest Asia theater in previous conflicts and during ongoing military operations in the region. We must remember that U.S. forces are currently deployed in Syria, Iraq, and Afghanistan at varying capacities. To truly honor their service, we must use all available data sets, interagency cooperation and agreements, and the health tools at our disposal to ensure that they will be taken care of as they transition from warfighter to veteran. I have full faith that both the Department of Defense and Department of Veterans Affairs want what's best for our troops and veterans. Yet, we continue to see heartbreaking stories in the news of young veterans' lives cut short. And just this week, I read a story of a healthy veteran in his 20s suffering from a rare pediatric brain cancer and tumors that are not typical for a healthy man his age. He was seen by VA and received treatment. However, this did not prevent his cancer from changing the course of his family's life, including his fiancee's. And at the time of this hearing, his family sits with him at in-home hospice. Today, I want to learn how we can reduce the likelihood that other veterans and their families will suffer similar experiences. For example, what takeaways from the recent National Academies of Sciences report can inform VA's working group and provide a pathway forward for presumptive conditions related to toxic exposures? What existing databases can be aggregated to help pinpoint veterans that may be at risk of developing cancers? What technologies can we harness to give VA relevant information about in-service exposure? It is imperative that we leave here today with a better understanding of where VA currently stands in addressing disability assistance for our veterans who have been exposed to airborne hazards in this theater of operations and the role Congress can play. I want to thank you again, Representative Luria, for holding today's hearing, and I look forward to hearing from all of our witnesses. And with that, I yield back.
Thank you, Chairman Takano. I also want to thank our distinguished witnesses for joining us today. We will start with panel one. On our first panel, the Department of Veterans Affairs is represented by Ms. Lori Carson, Deputy Executive Director of Policy and Procedures at the Veterans Benefits Administration Office of Compensation Service. Thank you. Good to see you back with us again. She is accompanied in person by Dr. Patricia Hastings, Deputy Chief Consultant of Post-Deployment Health Services at the Veterans Health Administration's Office of Patient Care Services and Public Health. Also from the VA, joining us remotely, we have Dr. Michael J. Falvo, Scientific Director of the Airborne Hazards and Burn Pits Center of Excellence at the War-Related Illness and Injury Study Center of New Jersey. And representing the National Academies remotely, we have Dr. Sver Vidal, Professor Emeritus of the Department of Environmental and Occupational Health Sciences of the School of Public Health at the University of Washington. Dr. Vidal is accompanied remotely by Dr. David A. Butler, Scholar and Study Director of the National Academies. Without objection, our colleague Representative Dr. Ruiz will join us for today's hearing. Dr. Ruiz has been a long advocate for veterans who have been exposed to burn pits, and we appreciate him taking the time in his schedule to join our hearing today. With that, I now recognize Ms. Carson for 5 minutes to deliver her testimony.
Thank you and good morning. Good morning, Chairwoman Luria, Ranking Member Bost, and members of the subcommittee. VA welcomes this opportunity to discuss VA's decision-making process as it relates to exposure to airborne hazards and open burn pits. With me today are Dr. Patricia Hastings, Chief Consultant of VHA's Post-Deployment Health Services, and Dr. Michael Falvo, Scientific Director for the Airborne Hazards and Burn Pits Center of Excellence. VA is committed to the health and well-being of veterans and will work with our partners to continue assessing the potential adverse health effects associated with airborne hazards during deployment. 1 in 3 veterans report possible exposure to environmental hazards, and 1 in 4 report health concerns due to deployment exposures. An estimated 3.5 million veterans have served in the Southwest Asia theater operation. To address veterans' concerns about military exposures, VA created Post-Deployment Health Services, which administers various programs related to environmental and occupational exposures. Along with the Department of Defense and partners from academia, VA is sponsoring and participating in multiple related studies. In 2019, Congress created and funded the Airborne Hazards and Burn Pits Center of Excellence. This has accelerated airborne hazards research and health care for veterans. We thank the committee for your support on this issue. As part of Public Law 112-260, VA established an open burn pit registry for individuals who may have been exposed to chemicals and fumes caused by burn pits in Southwest Asia. From its creation in 2014, the registry has accumulated nearly 2,114 participants. Approximately 500 participants enroll in the registry each week. On the issue of respiratory health effects from airborne hazards in Southwest Asia, the National Academy of Sciences, Engineering, and Medicine released its latest report on September the 11th, 2020. VA is grateful to the Academy for its review of this important topic, and we expect this report, combined with VA and DoD's work, to help develop an approach to prevention, medical care, benefits, and future support for veterans. In accordance with VA's established policy, a technical work group has started its review of the Academy's report in order to make recommendations to the VA Secretary. This work group consists of medical specialists, epidemiologists, pulmonary specialists, benefit experts, and researchers. While VA cannot speculate at this time on the outcome of this review, VA is assessing the matter carefully. Although much of today's discussion may include questions about formulating VA's presumptive conditions, we note that a presumption of service connection is not always required for veterans to receive compensation for service-connected conditions. When a presumption of service connection exists, It serves to remove the need for a nexus or link between the in-service event and a currently diagnosed disability. However, where there is not a presumption of service connection established, VA will still consider each claim individually on a direct case-by-case basis. VA requires minimal information to verify actual exposure to burn pits for veterans who were deployed to Southwest Asia. When a veteran files a claim and indicates burn pit exposure, VA claims adjudicators generally order a VA examination and request a medical opinion as needed to make a rating determination. Additionally, because there is no time limit for filing an original claim for service connection, VA will accept the veteran's claim based on burn pit exposure at any time after his or her discharge. From June 2007 through July 2020, approximately 12,582 veterans have claimed conditions related to burn pit exposure, and of that total, 2,828 veterans have been granted service connection for one or more conditions that were specifically related to burn pit exposure. It should be noted that veterans who did not explicitly file a claim based on burn pit exposure, but who otherwise served in Southwest Asia and were granted service connection for respiratory conditions may not be reflected in the numbers above. Madam Chair, this concludes my testimony. My colleagues and I are prepared to answer your questions.
Thank you, Ms. Carson. Dr. Vidal, you are now recognized for 5 minutes.
Thank you, and good morning. Chairwoman Maria, ranking member Boss, and Chairman Tucano, and members of the subcommittee, thank you for the opportunity to testify today. My name is Sarah Vidal. I'm the Emeritus Professor, Department of Environmental and Occupational Health Sciences at the University of Washington School of Public Health. I'm here today as a committee and a member of the Academy of Sciences, Engineering, and Medicine to address the respiratory health effects of airborne hazard exposures in Southwest Asia through military operations, Butler, National Academy here. In September 2000, the Veterans Administration asked the academies for
Dr. Vidal,
to study the evidence. Yes.
can I ask you to pause for just one moment? We are having difficulty hearing you in the hearing room, so if we could pause for 1 second, perhaps to clear up the audio issues.
Yes. Certainly.
Hi, Dr. Vidal. Can we just do a quick 5 count and let's see if we can get the audio cleaned up just a bit?
1, 2, 3, 4, 5.
Madam Chair, is that a little bit cleaner in the room?
Can we try one more time? And it also looks like Dr. Vidal might be using headphones. Perhaps that's causing some of the interference.
I'm going to try. Is that better?
Much better. I can hear you clearly now. Thank you. I apologize for the interference, and we'll start the clock back over, and you are recognized for 5 minutes for your statement.
Okay, I'll just continue where I was. I'll start over again. Chairwoman Luria, Ranking Member Bost, and Chairman Tucano, other members of the subcommittee, thank you for the opportunity to testify today. I'm Sarah Vidal. I'm Professor Emeritus of the Department of Environmental and Occupational Health Sciences, University of Washington School of Public Health, and I'm here today as a member of the committee formed by the National Academy of Sciences, Engineering, and Medicine to address respiratory health effects of the airborne hazards of the Southwest theater of military operations. I'm accompanied today by Dr. David Butler from the National Academy In September 2018, the Veterans Administration asked the National Academies to form a committee to study the evidence regarding respiratory health outcomes in veterans in the Southwest theater conflicts. I had the pleasure of serving on that committee, which included experts in epidemiology, psychology, exposure assessment, military and veterans health and toxicology. The report, as you've heard, was released earlier this month, and I'll summarize the conclusions and recommendations from that report. Our committee's review of the research found that veterans may be exposed to a broad range of potential hazardous airborne agents as part of their service in theater. These agents included dust, sand, as you've heard, emissions from open burn pits, air pollution from military vehicles and local sources, and then oil well fires set during the 1990-91 conflict, as well as a committee developed a list of 27 respiratory health outcomes that might be associated with exposure to such mortality, that is death, especially death from respiratory causes, cancer, asthma, chronic obstructive pulmonary disease, chronic bronchitis, and emphysema, sinusitis, restrictive bronchiolitis, and then other respiratory health outcomes of great concern to veterans. Of these outcomes, none of the outcomes met the committee's criteria for sufficient evidence association. They've heard the evidence for respiratory symptoms, that is chronic persistent cough, wheezing, and shortness of breath, met the committee's criteria for limited or suggestive evidence of an association in theater veterans. In addition, the committee concluded that the limited or suggestive evidence of no association between in-theater exposure and changes in lung function in the 1990-91 Gulf veteran or in that conflict. However, was insufficient or inadequate information to evaluate this association in post 9/11 veterans. The committee found that there was inadequate or insufficient evidence to evaluate the association between service in the Southwest theater and all of the remaining respiratory health outcomes we examined. The prominent cause for this conclusion was the absence of good exposure characterization. Information was often lacking on who was exposed, what they were exposed to, where and when, and at what concentrations, over what time period, and with what frequency. Other reasons include widespread self-selection into health studies and use of self-reported health outcomes and exposure, and the failure to account for the role of cigarette smoke. Our study wishes to emphasize that these findings do not mean that there is no association between military service and these conditions. It's clear that military personnel and veterans, as you've heard, deployed to theater are experiencing respiratory health problems. Our committee found that the available epidemiologic evidence, however, does not allow a definitive determination to be made about any potential association for most of the health outcomes. We developed a set of recommendations to address these information gaps and to advance knowledge on the respiratory health outcomes. It included a recommendation that VA establish an expert panel to advise it on issues related to the diagnosis of constrictive bronchiolitis, an issue of great concern to veterans and others, and its possible relationship to military service. A recommendation that an updated analysis of mortality, that is death, in particular respiratory mortality in Southwest Asia theater veterans, be conducted. And then a recommendation to the VA and Department of Defense explicitly integrate research access considerations into their planning as they refine implementation of their new interoperable electronic health record system. Generally, we recommend that VA expand its partnership with DoD on environmental health issues, with the free flow of information on exposures counted during military service and on the health of personnel before, during, and after deployment and after transition to veteran status. To more fully understand any existing association between service and respiratory health effects, our committee emphasized that researchers should take a new approach. It's possible today to conduct high-quality research by improving exposure assessment, combining and analyzing existing data in innovative ways, and better accounting for influences such as smoking and those resulting from selection of the studies. Burn pit-related research will certainly be part of this, but it'll likely be challenging to attribute specific effects to this one source. The more important question, I think, is whether exposure to The many hazardous airborne exposures encountered during deployment is responsible for adverse respiratory outcomes. That's why our report suggests a number of actions to address not only existing knowledge gaps, but also steps that VA and other government entities can take to better understand the health problems that veterans face. Thank you for the opportunity to testify, and I'd be happy to address questions that you might have.
Thank you, Dr. Vidal, and thank you for being patient with the starting over again. But we did hear you clearly once we got the sound problem corrected. I will now recognize myself for 5 minutes for questions, and I'd like to start by directing a question to Ms. Lori Carson. Ms. Carson, I understand that the VA is still processing the report, but I think we have to accept the reality that we may not have all the answers about burn pit exposure for a long time, if ever. But what we do know is that it's making people very sick. And I can't tell these people to sit down, to wait another 10 years, because quite frankly, some of them might not have another 10 years. So what can we do today?
So thank you for that question. I would encourage everyone to file their claims for benefits if they believe that they are suffering from a disability in military service. Also, to join the VHA's burn pit registry, and I'll allow my colleague, Dr. Patricia Hastings, to talk more about that.
I'd be very happy to. We have two. Thank you so much. Very happy to. The registry, which was created by an act of Congress, has been very helpful to be able to data mine it for trends and look at building cohorts for studies. Unfortunately, it's an opt-in system. And every time there's a hearing such as this, we do see the numbers go up a little bit, so thank you very much for helping add to the registry. DOD is doing a lot to get people into the registry. When you come out of the TAP program, the Transition Assistance Program for Retirement, they talk about the benefits of the VA, they talk about the Airborne Hazards Registry. Recently on the leave and earnings statements, DOD put out information about the burn pit registry, and we'll see the numbers go up. But if it was an opt-out system where there was more encouragement or a method of putting people who had deployed to Southwest Asia or other areas of concern, that would make it easier for us to track them. One of the things that's coming up is EILR. I know we've talked about that before, and that's one of the most exciting things coming forward, and it's the individual longitudinal exposure record. At the time you come into service, your record will start. This started in 2013, got really going in about 2016, and it's in its initial operating system right now. And the feedback I've gotten back from doctors in the VA who have used it say this is great. This is very helpful because it matches a person to a place to an exposure and any monitoring that's been done.
But can you just clarify, that would only be for future use? That's not going to capture past exposure?
It does go back. It's going to be better for future use. You're absolutely correct. The data from 2002, because we have the Defense Manpower Data Center information there for where people deployed, and we can go back and say, okay, there were these exposures here, but monitoring wasn't that good before. It's getting better and better. We're also looking forward for individual wearable monitoring, as well as just more monitoring by environmental science officers in the field, because we understand how important that is. The other thing that it will do is when we build research, even though the information gets better as it goes on, we'll be able to look back and say, these are things that were not addressed before. These are studies that were done. These are findings that will also help people that were our predecessors.
So I noted in the statement and the report from the National Academies of Science that the information gained from the burn pit registry in their assessment has very little epidemiologic value because of the fact that it is self-reported, and that creates a sort of bias as to the amount of information and who it's received from, and why someone may report. So can you comment on how the VA is using that information if the National Academies of Science is saying that it's not valuable information for their research?
I'm so sorry. It's not as good as it could be because it is self-reported data. But it does a couple things for us. One, it gets people thinking about what their health is like, and then also it gives them information. We do mailings. For example, when COVID came out, we did a mailing for everybody in the burn pit registry to say these are things to worry about. We also can look for trends. I can tell you right now that
Can I pause you for a second? So you recognize that people are signing up for this burn pit registry because they feel that they have some sort of respiratory problem. And you're acknowledging that by then sending them information about a current virus that has respiratory effects. So we all see that there's a link there. You breathe in dust and toxins and particulates and smoke 24 hours a day when you're deployed. Just common sense says, how can this not impact your lungs and therefore your health? And we don't even know what all the toxins are that they breathed in. So it seems like you're even conceding right here and now that there are health effects to what they breathed in, yet we're not getting to the point of saying, like, we can have presumption for this. So I don't know if you or Ms. Carson would comment on that. I mean, it seems as though you've just admitted it here in this hearing.
I'd be happy to. There are many people in the burn pit registry that do not have problems. In fact, that is probably the majority, and they're signing up with the idea that they might want to have future information. And yes, the biggest risk for people with COVID for mortality is pre-existing medical conditions, and mostly the things that you've heard: aging, diabetes, hypertension. But if someone has a respiratory condition, we would worry about that too, just like any of the other conditions. But we send them information. We look for trends. I can tell you that asthma is number 7 in the complaints that people have. Most of the complaints that people have that we have in the burn pit registry actually are musculoskeletal, insomnia, and a couple others. Asthma is number 7. But we can build cohorts where we can really do rigorous research, some of which is in the book that National Academy just put together for us, which thank you very much for funding it. It's an important study. We have started the review of it. The review is done under Directive 0215. It's a very precise review with timelines. The technical working group is consisting of specialists in all fields as well as our colleagues at VBA. This will be an important piece of work. We also are working with the information that has come out from other areas that might not have been available at the time to the National Academy, and this is with my colleague at the Airborne Hazards Open Burn Pit Center of Excellence in East Orange, New Jersey, which you support. Thank you very much. And I think you also have seen the research that we provided to you, the list that was put together by Dr. Falvo, which is very extensive with the recent articles that have been published, the active studies, and then the completed studies that VA has done. We are committed to getting answers. We know that the science is not the best, and so we are looking at the ambiguities, and where there are ambiguities, I can assure you that the benefit will be given to the veteran.
Well, thank you. And for my colleagues, I apologize. I went over my time. So I will likewise allow you a little additional time so that we can get thorough answers. And thank you, Dr. Hastings. I will now recognize Mr. Boss for 7.5 minutes.
Thank you, Madam Chair. Dr. Hastings, if Congress were to legislate evidentiary thresholds that would require the VA to establish presumptive disabilities, can you speak to the benefits of requiring a higher degree of scientific certainty, such as sufficient evidence of association and or evidence of causal relationship on how that would help?
Well, we pay a lot of attention to the National Academy's levels of evidence that they put together. And they've got 5 levels of evidence that you've seen. They've only used the sufficient for causal once in one of their reports from the Gulf War, and that was with benzene for leukemias. But they have the level that is the sufficient to determine an association, the limited or suggestive for an association, limited or suggestive of no association, and then no association. And so they look at the levels of evidence when they put together the consensus reports. And we take the report that they've given us, we go over it very carefully. We look at any new science between the time that they've completed the report and when they quit looking at documents. And there is a considerable amount that's coming out all the time. So I believe if you give us the time to complete the review of the National Academy report as per Directive 0215, and you can Google it or I can get you a copy of it, it's very precise to make sure that we get the right information to the Secretary so he can care for veterans, and we can give you a report that shows you we are doing our jobs.
Okay, that was an answer, but I don't think it got to where the benefits of requiring a higher degree of science certainty. What are the benefits that?
Well, we want to have some science with it because in fact, if I cut off the science right now and I say everybody just gets benefits for burn pits, and I don't care about the science anymore because the benefits are there. There are some people that will be harmed because there are some people who have respiratory symptoms. They're not referable to burn pits. And I'll ask my colleague in just a moment to comment on this, Dr. Falvo at the Burn Pit Center of Excellence. Some people with PTSD, some people with blast injury have respiratory symptoms. So we would not want to simply say everything is burn pits. We really do want to get to the right diagnosis, the right treatment, and the right care for that veteran. And if you don't mind, I could ask Dr. Falvo.
That's fine, but let me ask this, because what you just brought up with, I understand for the doctor's sake, you want to know what the exposure was, but for the benefit's sake, it doesn't matter as far as long as they have a presumptive, so that then they can receive the treatment at the level that they deserve. So it really doesn't. I mean, the VA, as far as we're concerned, they should receive the benefits, and then it would be between them and their doctor on where the exposure was.
You are absolutely correct. They all tie together, and getting to the right diagnosis would also get to the right disabilities and the right level for that. You're absolutely correct. They all tie together.
All right, well, you said, would someone?
Dr. Falvo, if you could comment just on some of the research that you are doing with regards to respiratory symptoms that may not have a seeming burn pit cause.
Yes, ma'am. Thank you, Dr. Hastings, and thank you, Ranking Member Bose, for giving me the opportunity to comment here. With respect to your earlier question about the benefits of identifying the important science, and whether it's attributable to burn pits or not, we're concerned for a few reasons. Well, one is there's complicating factors, and we found information that that's published in the literature now, some of which is available in the report, that the co-occurring factors such as exposure to combat violence and stress play a really important role. So do physical activity, so do tobacco smoke. But really importantly, we've also known that there's non-inhalational exposures that also play a role too. One example is exposure to blast during deployment. We were actually able to use information from the burn pit registry to identify this relationship between blast exposure with respiratory symptoms. Even accounting for self-reported exposure to burn pits, we still saw that relationship. So we're very much learning a lot of new questions and exploring different opportunities to understand what's really affecting veterans' healthcare.
All right, thank you. And Dr. Vidal, I need to ask you, the NAS recent report discussed how gaps in the knowledge of a veteran's estimated exposure to airborne hazards may limit our understanding of the possible nexus between the exposures and certain health outcomes. Can you kind of explain whether research could be conducted to retroactively measure the veterans' potential exposure to toxins from the burn pits?
Yes, can you hear me better now? I've been routed through my phone. Does this work?
Yes, we can hear you.
Ah, great. Yes, so that was actually of great interest to us in the committee, that there are technologies now that can be used to historically estimate exposures. And one of the main issues, as you've heard about the current science, is that often the exposure assessment is pretty crude, oftentimes just deployed versus non-deployed. And we heard in testimony before the committee that there were several exciting things going on currently, and also things that can be done. One of the more exciting ones is actually using remote sensing from satellites to estimate previous historical exposure in theater. With respect to burn pits, there's NASA information on burn in the in-theater that can be used for that purpose to historically estimate exposures. And this could be done fairly smartly, and there's already work going on using some of these remote estimates of exposure in studies. So we know it's possible to do. So that I think would be a big step forward in trying to validly assess the association from a scientific perspective.
Thank you. My time's about at an end, and I'll yield back.
Thank you, Mr. Boss. I now recognize Mr. Takano for 5 minutes.
Thank you, Chairwoman Luria. Ms. Carson, my first question is for you. Based on your testimony, I understand that VA is reviewing the National Academy's report and that an established working group will provide recommendations for the Secretary's consideration. Now, what I want to know is, are there lessons learned from VA's work on the Agent Orange presumptive list process and the Gulf War illness that could help improve the time it takes the working group to speed up its recommendations? I mean, we don't want to see a 40-year wait like we did with Agent Orange. So can you comment on that?
Thank you for that question. I will actually ask my colleague, Dr. Patricia Hastings, to comment because her office is the entity that spearheads the working group. Dr. Hastings?
Dr. Hastings, go ahead.
Yes, very happy to answer that. No, it's not going to take 40 years. I think Agent Orange was one we, as you pointed out, learned a lot from because we had waited a long time. We did not know about Agent Orange and the dangers of it at that time. And we are now looking, I mean, my office was started specifically to look at post-deployment health issues. I'm a veteran of 33 years. I served in the U.S. Army. Kudos to you for being in the Navy, among others that are military in this group. So no, we will not take that long. We have learned lessons, and that is exactly why we have Directive 0215 to move the review very quickly through, to be looked at by subject matter experts, then to be looked at by policy people in the strategic working group to make sure all answers are addressed, and then it will go to the task force to ready it for the Secretary.
Well, Doctor, could you just give me a couple examples of lessons that you think we've learned? Just a couple of lessons that will
Absolutely.
won't make this next process so lengthy?
We are engaged in research, and Dr. Falvo at the Burn Pit Center of Excellence can talk to that if you would like to. But we have learned that we continuously need to look at what are the important issues to veterans, what are the things that in some cases are appearing in the media, what are the trends that we see in the registries. And yes, it's self-reported data, but it can give us an idea of what we need to look at. It can help us build cohorts. So I can tell you we are very actively researching constantly. We are looking at what are the things that need to be addressed for veterans. We work very closely with our VBA colleagues to ensure that the healthcare issues are addressed, but also the disability and the benefits issues are addressed. And I don't know if Ms. Carson has anything more to say about that.
I would say that some lessons learned from the benefits aspect would be that we have integrated project teams. So our teams are designed so that when we do come to a conclusion that we need to establish a presumption, that we ensure that as we are writing the regulations, which take on average about 24 months to write, that in that period of time we also bring a collaborative team together that's enterprise-wide to address all of the issues, because now when we roll out things, we try to have our IT systems and things working, as well as identify when it comes to a presumption, whether or not we need a special centralization of that workload. So we do all of that as well.
Okay, well, Ms. Carson, you mentioned in your testimony that 12,582 veterans have claimed conditions related to burn pit exposure, and that a total of 2,828 have been granted service connection. You also say VA frequently sees 5 conditions: bronchial asthma, allergic rhinitis, sleep apnea, bronchitis, and sinusitis. Do all 2,828 veterans granted disability related to burn pit exposure have one of the 5 conditions you've listed?
And others, and there may be other conditions associated, mostly respiratory conditions. So out of the ones that we have granted, yes, they have one of those conditions that we see.
They have at least one of those conditions?
At least one.
Okay. From the remaining 9,754 veterans not granted disability related to exposure, are there other burn pit exposure-related conditions that seeming to trend at a high rate?
For the remaining, oftentimes there's no diagnosis or is no evidence that it occurred in service at this time.
Okay. All right. Well, Dr. Hastings, you oversee the post-deployment health services at VA. So from the 5 conditions listed at VA's testimony as most frequently cited for burn pit exposure claims, how many of these issues are listed on the burn pit registry questionnaire? All of them are? Did VA's PDHS or post-deployment health service questionnaire inform VBA's disability grant policy? I'm sorry. Did VA's PDHS or the post-deployment health service questionnaire inform VBA's disability grant policy?
I would have to refer that to this person.
Yes, sir. We use information from the Office of Post-Deployment Health and other scientific literature in a form of a fact sheet that we use with our medical examiners when they have to do examinations, as well as with our rating veteran service representatives. They are to consider information that comes through the Office of Post-Deployment Health and other research.
Okay, finally, are there any other conditions that veterans list as symptoms or perceived symptoms of exposure to burn pits during their deployments to Southwest Asia?
I'll ask Dr. Hastings to comment.
The most common symptoms that are reported are the ones that were in the National Academy, and that was the wheeze, shortness of breath, and cough. 4 symptoms. Those are the most common.
All right, well, thank you. I yield back, Madam Chair.
Thank you, Mr. Takano. I now recognize Mr. Bilirakis for 5 minutes.
Thank you, Madam Chair. I appreciate it very much. I think there's general consensus here in this committee on both sides that the status quo on this is definitely not enough. And I believe there needs to be a standardized process on legislating and regulating presumptive disabilities at VA for these and any other future toxic exposures. I've said that this is the Agent Orange of our era, and I think most everyone agrees. And my bipartisan legislation I authored with my good friend, Dr. Ruiz, who's here, as co-lead, H.R. 4086, the Protection for Veterans Burn Pit Exposure Act, and I thank Dr. Ruiz for creating the caucus as well. But this particular bill takes this presumptive framework by mandating that VA make determinations on diseases that may be associated with exposure to burn pits and other airborne hazards within 60 days of the NAS reports. Dr. Hastings, this is the question. Dr. Hastings and Ms. Carson, can you describe VA's current process for reviewing current research and scientific evidence, such as the recent NAS studies, and subsequently making recommendations to the VA for the establishment of presumptive disabilities? And second question, and is there laws in place? Are there laws in place that prevent VA from establishing these presumptions without congressional intervention? I know that there is precedent for that, but if you can answer those questions, I'd appreciate it. Yeah,
Yes, sir. In regards to the presumptions, as described, we use Directive 0215. 60 days would be pretty tight. I really do like the 90 days that we have now in the directive, because that gives us a chance to bring together scientific experts, our VBA colleagues. We can also do external communications with any of the other federal agencies or academia to get additional information. It does take some time to pull some of those things together. We then give it to the strategic work group. The review there is fairly quick because they make sure that all of the issues have been addressed. And then it will go to the secretary. So it is not 60 days, but it is a compressed process. And it was put together to make sure that we would do it quickly, as described for Mr. Takano. Very important way to do it is to get it through the system and address the National Academy reports and get answers for Congress, get answers for veterans, and get answers for ourselves at VA.
Okay, Doctor, do you want to add something, please? Okay, again, you didn't answer the question with regard to the presumption. Can this be done, established without congressional authority? Can it be established by the VA?
If you'd allow me.
Yes.
The VA secretary has broad authority for service connection, which includes the ability to establish presumptive disabilities in conjunction. Generally, the process that Pat just described is a process that gets a recommendation to the secretary. He may require additional science or additional research and studies to be included to make a well-informed decision. And in general, when he makes that determination, it is announced in the Federal Register, and then we also work with OMB.
Okay, thank you. Dr. Vidal, your testimony discussed the NAS Committee's recommendation that VA conduct a study on the mortality of Southwest Asia theater veterans. I agree that this is important. It's an important undertaking. It seems abundantly clear to me that many veterans exposed to toxic exposures came in healthy and are leaving sick with respiratory symptoms, and in many cases, tragically dying. I've had veterans in my office that have testified to this as well, and their families. Can you discuss how this recommendation would help further understand our understanding of the possible health effects of exposure to airborne hazards such as burn pits? I just want to make sure that these heroes get health care. And even if it's not combat related, or if you qualify for health care under the VA for another injury, combat injury, I want to make sure that our veterans, this is the first step, they are taken care of with these symptoms, particularly respiratory symptoms. So if you could answer that, Dr. Hastings, I appreciate it. And how many?
Did you mean Dr. Vidal or Dr. Hastings?
Yeah, well, Dr. Vidal first, please. Thank you.
Yes, thank you. Yes, with respect to the committee's perspective, we were well aware of testimonials and others that reporting conditions related to service. And we were expecting, I think, to see some associations based on the literature, particularly for asthma and sinusitis. But we were disappointed. And frankly, the scientific evidence was not up to par. Now, with respect to mortality that you mentioned, and that was your specific question, those studies can be updated. That is, the studies previously had a very short time window and a time frame, and one might not necessarily expect to see a relationship with mortality in light of that. That does need to be updated. However, the issue before the committee is what can be done that's going to be helpful, and mortality certainly will be, but mortality is also a high bar. To expect to see associations with mortality is a very high bar relative to outcomes such as symptoms that you mentioned, which are frequently reported. So I think the work needs to be done. It's relatively easy to do and can be done smartly. But in terms of whether we should be optimistic about the findings of a study like that, where mortality is, I think, asking a very specific question that, as I mentioned, has a fairly high bar, I'm not sure that's going to satisfy, your concerns in the short term.
Okay, thank you, Doctor. I know I have to go, but again, I just want to make sure, again, this is the first step, and we want to make sure they get disability benefits as well. So we're pushing for the presumption. But are there veterans out there that need the care, that have these symptoms? I mean, my goodness, they came in healthy and they're leaving sick. They need to be treated by the VA. Are they being not treated by the VA if they qualify for another combat-related injury or what have you? Are they being treated for these symptoms caused by burn pits exposure? I mean, we don't have the scientific evidence yet, but we're getting there. But these people don't have time, and their families are suffering for it as well. So, can you answer that question quickly, and then I'll be done.
Yeah, I would have to maybe defer to Dr. Falvo, who sees a lot of these patients, but I think there was a sense of frustration on the committee that we felt that there clearly were conditions that service members were reporting. We didn't have the luxury of using just pure testimonial evidence to make our decision. We had to rely on the science, and on the basis of that, that's how we came to our conclusion. So with respect to treatment, I perhaps may have to defer to Dr. Falvo as to the likelihood of them receiving appropriate treatment.
Thank you.
Yes, just for Dr. Falvo or Dr. Hastings, can you please limit your response to about 1 minute for this so we can allow other members to have time for questions?
And I'm sorry, Madam Chair, for going over. It's just that this is so important.
No, it is, and I also went over, and I want to make sure we get thorough answers as well, so thank you.
When veterans, when someone becomes a veteran, they have 5 years to come to the VA for health care at that time. And we do encourage them to do that and to enroll in VA health care. And there is also, in every single VA medical center, there is an environmental health coordinator and clinician. And so for exposures, they can come in and get an airborne hazards exam. They may decide that they're getting their health care elsewhere, but they can come in and get an airborne hazards exam, discuss their conditions, if they have any, or their concerns, or what they'd like to do for future care with that environmental health clinician, and be in the burn pit registry. And if they're healthy, that's great. If there is a problem, they can help them enroll in VA healthcare. They can help them get to the right people for benefits, or they can send back information to the person who is caring for them.
Okay, I'll get back, Madam Chair. I took too much time, but I appreciate it very much.
No, thank you, Mr. Bilirakis, and I think we'll probably have time for a second round of questions, but I just want to make sure we get through everyone first. So we'll now recognize Mr. Cisneros for 5 minutes, or 7.5 minutes, to be fair.
Thank you, Madam Chair. I want to thank our witnesses for being here today, for your time in answering our questions today. And I also want to recognize my colleague, Representative Ruiz, who's been working tirelessly on this issue around burn pits to hopefully prevent us from facing another Agent Orange. So the National Academy of Sciences Airborne Exposure Report, released on September 11, 2020, did not reach many concrete conclusions. The report has some limited findings of association between airborne hazard exposure and non-specific respiratory symptoms like chronic coughing, wheezing, and shortness of breath. I understand that more study is needed in order to help develop conclusive results, but given the number of veterans suffering now, time is of the essence. So Dr. Falvo or Dr. Vidal, how can we better study the effects of airborne exposure moving forward to yield more conclusive results?
Thank you, sir. I'd be happy to respond to that. That's okay. So one of the comments that Dr. Vidal made in his opening statement referred to the innovations that are available to us now and some of the work that could be done. One of those was remote measurement and to be able to do a retrospective estimation of airborne pollutants in theater. So that's currently underway. That's a VA-led study that's provided in the bibliography that we gave to the committee. And this is referred to as the Cooperative Studies Program 595. So I think what this demonstrates is two things. First, the VA is committed to strong science, and that's not just monitoring it, that's actively supporting and performing it. Also, with this study, this is a VA-led study, but it partners with the Department of Defense, NASA, as well as academia to find the right results for veterans. So there's a number of questions that need to be answered, many of which are currently being answered right now, but still many more that require attention.
All right, so with this study, that will be for going forward in the future, but how do we get better results with those that are currently suffering from these side effects?
That's a great question. Actually, with respect to that cooperative studies program I just mentioned, that actually uses retrospective data. It goes into the past and is able to use NASA satellite data that's archived in order to understand particulate matter exposure.
All right. So many of the existing mechanisms for collecting data and tracking health conditions for veterans exposed to airborne hazards place the responsibility on veterans to proactively participate. The burn pit registry, for instance, is used to improve programs and help veterans with development concerns, but I understand there's been limited participation, and I have concerns a lack of awareness may be contributing. So how can we provide an overview of some of the improvements the National Academy of Science has made to improve the registry, and are there specific changes that might help improve participation for veterans?
I will ask my colleague to talk about what our process is.
With regards to the registry, we have made it easier for people to get into the registry. In a previous look at the registry in 2017, the National Academy gave us 9 different suggestions, 9 recommendations for improvement. We accepted 8 of them. One we disagreed with. They talked about getting rid of the hobbies questions. And hobbies questions doesn't stop anyone from completing the registry. Most people put down none, but there are some hobbies that could have an impact on respiratory health. For example, if you made your own bullets or made stained glass windows or raced pigeons, could have an impact on your respiratory health. So those were helpful questions. The other recommendations of the National Academy have been put in place. I will note that you also, in Congress, put together funding for us to go out and ask veterans what they thought would be improvements to the registry, and we are actively doing that right now. We work with the VSOs. We have an airborne hazard symposium each year. This year it was virtual, but we invite the VSOs and work very closely with them. VBA and VHA both have VSO liaisons to get information out to them, and I can tell you as a veteran, at 30 days, 60 days, 90 days, 360 days, and 720 days, I got messages to tell me about the burn pit registry and other VA programs. So we are trying to get the word out. I think DOD is working hand in hand with us to do that with the messages that they are putting out. And they also use social media, as do we at the VA. I would like to see more emphasis on the burn pit registry so that we could build larger cohorts. We'd have more people that we could provide information for. But I also would say that when we get the study done looking at how we can improve it from the veterans' point of view, I would like to offer a briefing to this committee to tell you what your money found.
So can I ask, so again, that's the emphasis is put on the veteran or the service member to participate in these programs. Why not work with DOD as part of their separation process? We know where they were stationed. We know, where they served. Why not have them sign up for it as they leave active duty service?
It actually is included in the TAP program now. You're absolutely correct. That's a way to do it. And the Transition Assistance Program spends one day on VA and talks about VA healthcare, VA benefits, talks about the burn pit registry.
Yeah, but that's in the TAP class. That's different from actually being separated. Why not make it part of the separation paperwork? Why don't we kind of work with DOD to get that done?
I can work with DOD. I meet with them monthly and see what they think about that. But I will tell you, before I could leave the military, I had to have that paper signed that said that I learned about the burn pit registry. They encourage people to sign up, and I would like to see more emphasis on that to encourage people to do it. There might be the option of being entered into the registry, and then you would have to opt out because it's easier, to just not do it than to to actively go in.
All right. I think that would be better to opt out rather than to have people opt in. You would get more people signed up for it. So in this last question I have is really just open up to anybody on the panel, but what mechanisms currently exist to identify potential correlating symptoms should they develop after they leave the military and are either utilizing civilian medical providers? And are there improvements you would recommend to ensure veterans outside the VA system who are seeking medical treatment are not only able to connect to resources, but also able to ensure the data becomes part of ongoing research?
I'd be very happy to talk about that. We don't work a lot with our civilian counterparts, and that's why the Airborne Hazards Open Burn Pit Registry exam is very important, because that will get them into the system so that even if they're getting health care outside, we can make sure that they get updates, they get information that's sent to them in regards to burn pits. Until there is a national health care record, that will be difficult to do. I will say that every bit of training that we've put together in my office, and it's everything from Agent Orange to Gulf War to burn pits and airborne hazards, is available to the civilian community. We have something called the training management system that I have to keep all my education up for VA issues. But it's also available to the civilians on something called Train. And we work with our community care representatives to make physicians aware of that.
Again, so some of the readings I've done that I've seen, right, or talk about why we haven't been able to get good, strong, conclusive evidence is because the number of individuals that aren't seeking treatment within the VA, that people are getting their medical care outside the VA system. How do we bring them into the system? How do we collect that data? I mean, what recommendations do you have in order to do that so we can get more participants in this research and get stronger, hopefully more conclusive data?
With people who are not getting VA health care, if they are in the registry, we can contact them and build cohorts that include them, and that would be very helpful.
All right, so kind of brings me back to my point, why it's important to get people signed into the registry out of active duty service and kind of make their civilian doctors aware too of how to participate in this research. So with that, I yield back my time.
Thank you, Mr. Cisneros. I would now like to recognize Dr. Ruiz for questioning and fairness. Most members have taken about 7.5 minutes.
Thank you so much, Chairwoman. It was an honor to previously serve on the Veterans Affairs Committee, and it is great to be back to address two basic, simple, pertinent questions. One, whether or not burning trash near military bases affects the health of veterans, and two, whether or not we should take care of sick veterans after toxic exposure. So the answer to both is yes. I want to start by asking Ms. Carson from the VA a simple question. Would you consistently burn solid trash in your backyard or near your family?
No, sir, I would not.
Correct. In fact, burning solid trash or waste was outlawed and banned in the United States way back in 1979 because of the obvious health effects that burning trash near a human can cause. So my next question is to Dr. Vidal. Doctor to doctor, I'm an emergency medicine doctor, public health expert. What potential illnesses could a healthy person develop if they consistently burn solid trash in their backyard?
Yeah, I think the ones that have been mentioned are the ones of most concern, and they include, the upper respiratory illnesses such as sinusitis, potentially allergic rhinitis. We were particularly concerned about new onset asthma, and I think that would be a prominent issue. And then I think finally, some of the chronic obstructive syndromes such as chronic bronchitis would be another issue of concern.
Okay, thank you, Dr. Vidal. Currently, the VA website says that, quote unquote, research does not show evidence of long-term health problems from exposure to burn pits. I got to make this very clear for everybody watching and for everybody here today that this statement is misleading. It is very misleading. For years, the VA and the DoD have cited the 2011 Institute of Medicine report of previous studies to show the lack of causal link. And now they cite the 2020 National Academies report, which concludes the VA's favorite soundbite, quote unquote, inadequate or insufficient evidence to determine an association. However, both reports say that the data they needed to draw a positive association was simply not available. To be clear, a causal link could exist, but the data was either not provided or not collected. The right questions were not asked, including questions regarding cancers, and the right methodologies were not used. So I'm an emergency medicine physician, public health expert, and in public health and in medicine, it is practice that if there is a high enough probability, in other words, a high enough suspicion of a harm that causes a severe enough illness, then we need to act on that probability. We need to act on that suspicion. So while the VA and the DoD claim to lack sufficient data to establish a causal link that veterans exposed to burn pits are developing serious respiratory issues, we have independent research that raises high probability, that high suspicion of a causal link. Both the 2011 and 2020 National Academies report found dioxin to be of concern because of their association to burn pits and because some of the concentrations exceeded U.S. air quality standards. As we know, dioxin was present in Agent Orange. So why do we have to wait for that perfect study to show a causal link between a carcinogen and the brain cancers, pancreatic cancers, esophageal cancers that our veterans are dying from? We know that dioxin causes cancers. In addition, in an article published in the New England Journal of Medicine, Dr. Miller from Vanderbilt University performed lung biopsies on 49 soldiers exposed to burn pits in Iraq and Afghanistan who were healthy before being deployed. 38 of them were diagnosed with constrictive bronchiolitis. Another study published in the American Journal of Men's Health by Dr. Zima reports that, quote, some soldiers have been found to have metals in their lungs with iron bound to titanium in fixed mathematical ratios, unquote. We also have many case studies that seem to raise extremely high probability or that high suspicion. So my constituent is one of those, Jennifer Kepner, a 39-year-old Air Force veteran with a healthy lifestyle and no other risk factor, died of pancreatic cancer, leaving behind her husband and 2 children. By the way, her benefits were denied from the VA initially until my office had to get involved. Her oncologist determined that her exposure to burn pits was the most probable link to her cancer. Dr. Vidal, in your testimony, you say that, quote, many of the studies considered were limited by an inability to confidentially rule out chance, bias, or confounding as an explanation for the results observed. Let me ask you a question. Do you think the results in the studies I mentioned happened by chance?
I think your question is a fair one, that we had a high suspicion based on the exposures and what was entailed in the exposures, that there were going to be associations found. But as you heard, there are serious limitations in the studies. You know, we could certainly try to incorporate prior probabilities, and you're aware of that, you know, use in trying to influence the conclusions that you draw. But based on the data and the findings, I don't think we're allowed to. We don't have the luxury of going beyond what the data showed. So, for example, you brought up the issue of the constrictive bronchiolitis and the report that caused a lot of interest, and one of our recommendations was, in order to try to move that further, was to establish a panel in order to assess those biopsies. There's been a lot of controversy about those biopsies, and I think your statement
on the face value was correct, but it
So,
doesn't
Dr. Vito,
explore-
do we, if we know that an agent causes a specific illness or has high risk of causing the illness, in one scenario, like during 9/11 with jet fuel being burned and you have firefighters and first responders now dying from cancer and other lung diseases, then why do we have to repeat those studies when we know that those same agents were used and burned during burn pits? In other words, if we know that jumping off of an airplane without a parachute will cause death, then why do we need to have that study to confirm that jumping off an airplane would cause death? Why do we need another study when we know that dioxin causes cancer and dioxin was found in high concentration near burn pits? You see, our veterans cannot afford to wait decades for the perfect 20-year longitudinal double cohort study like they were forced to with Agent Orange. We have all the evidence needed to avoid repeating history and remove the burden of proof from sick veterans. In 2006 and 2011, environmental engineers Lieutenant Colonel James Elliott, Lieutenant Colonel Darren Curtis, respectively, sent a memo to their supervisors at the Department of Defense sounding the alarm about the health effects of burn pits in Bagram, Afghanistan, and Balad, Iraq. The 2010 VA published a training letter with a list of all the chemicals service members were exposed to, acknowledging their severe health effects. In July 2020, the Department of Defense reported to Congress that, quote, there are service members and veterans whose chronic respiratory conditions may be associated with their deployment to Southwest Asia, unquote, and that, quote, burn pit emissions contributed to the total amount of pollutants to which deployed personnel were exposed, unquote. We cannot wait. Veterans are sick and dying. And that's why we're here today, to ensure the VA and the DoD cannot neglect this DoD self-inflicted wound any longer, that we avoid delayed casualties of war. Last week, I introduced HR 8261, the Presumptive Benefits for Warfighters Exposed to Burn Pits and Other Toxins Act of 2020, which would establish a presumption of service connection necessary for veterans who develop respiratory diseases and cancers from toxic exposures. How can we send troops overseas to keep Americans safe and then turn our backs on them, especially when it is our own military's policies that are making them sick and killing them? So I look forward to continuing our work to get this bill signed into law and take care of our heroes. Let's not turn a blind eye to the obvious. Burning solid waste in the United States was banned because it's harmful to your health. Burning solid waste in 10-acre pits where you have black smoke, including burning jet fuels, plastics, military equipment, medical waste, other solids and chemicals that have known toxins, known dioxins with a plume a mile high that is exposed to our service members enough to where their faces are covered with soot when they go to bed at night. And now we're trying to prove that dioxin can cause cancer in our veterans, when those questions aren't even answered in our studies, and we're twiddling our thumb trying to figure out if what is going to be the next study to prove that carcinogens cause cancer. So let's not forget the big picture here and common sense. I'll go toe to toe with any one of you in looking at scientific studies, given my background and my training at Harvard Medical and School and the School of Public Health.
Dr. Ruiz.
So let's not kid ourselves with what's obvious. So let's start acting on this and act on our suspicion and save some lives and prevent this from happening. And I yield back my time.
Thank you, Dr. Ruiz. And we will be doing a second round of questions, so we will give you the opportunity to speak again if you would like to stay. I will now recognize myself for 5 minutes, and in interest of time, we are going to hold everyone to 5 minutes during this second round, since we gave additional time during the first round. I'd like to address my question to Ms. Carson. So right now we have veterans who are applying for disabilities related to this burn pit exposure, and they're being denied. And going back to your testimony, between June 2017 and July 2020, there were 12,582 veterans who've claimed conditions related to burn pit exposure. Of that 2,828, and these are the numbers that were in your testimony. Veterans have been granted service connection for conditions specifically related to burn pit exposure. So that's less than 1,000 claims a year, and that's a 78% denial rate. And over this period of time, millions of veterans have been granted service connection for other conditions, but less than 3,000 for burn pit exposure. And why are we seeing such a high denial rate? I think that's what we're all trying to get after, is because, you know, like Dr. Ruiz said, where none of us is burning tires or trash in our backyard and causing our families to breathe this in all day, every day for 6 months or a year deployment length. And so we know it's not good because we don't do it here. And there's people who are coming back and they are saying, I have these health issues, but they're not getting their claims approved. So what else does the VA need to make sure that we can get these people the care that they need?
So because the decisions we make are evidence-based decisions that are generally driven by the in-service event and the known exposure, the science and the research that's being done now is very critical and important for those veterans who have been claiming disabilities that are well beyond their period of service. In general, the ones that we can grant—
So when you say well beyond their period of service, you mean it's a long time after that service
that
happened?
they've established a disability that we oftentimes can't directly link to their service, or in the 1 year or 5 year period thereafter, we don't see them. They generally come to us, they have a respiratory condition today, but they served 10 years ago. Some of the challenges are finding the link between that in-service event and the current condition that they have, because there are all types of intervening issues or exposures that may have happened as well. So our responsibility in our organization is to determine those disabilities which can be linked to their military service. So with the science and with the studies that we're doing, we are definitely looking at what are those disabilities that may be presumptively related to service connection, but right now we don't have that because we are still in the process of studying that, but we can only directly service connect.
So give me an example of a veteran who did get approved for this. What did they have to do? What hoops did they have to go through to come in with a respiratory issue and actually get a claim approved as someone who had a service-related illness from the burn pit exposure?
Sure. So veteran John Doe comes to VA maybe 6 years after his military service with a respiratory condition that he believes is related to burn pit exposure. He submits information about where he was and what was burned. We verify that with DOD. We also get his service treatment records.
But how are you verifying it? We've said 100 times through this hearing and all the hearings we've had that you don't have any way to verify what was burned.
We don't, not the actual contaminants that were there, but we do ask DOD about the exposure event. And DOD tells us about exposure events. So they'll say, yes, he was near a burn pit or not. That usually is in the record, or he's in an area that's known to have used burn pits.
So why even have that step? We know there were burn pits. We know the period of time. The National Academies of Science is saying that there's even more data out there to help us map this through NASA and NOAA satellite data and, you know, what we can trace as toxins going into the air. So, you know, it's like the Blue Water Navy thing. We're back to this whole situation of let's go look at the deck logs from a ship from 50 years ago. And we're doing that now 50 years later for Blue Water Navy veterans, but like right now we can say there were burn pits in Iraq and Afghanistan and other places in Southwest Asia, and this person was deployed there. So
correct.
It's still a hurdle we're putting on the veteran when it's known that they were there and they breathed these toxins.
VA actually goes out and verifies that, but it's just that threshold is very low in that if you were in Southwest Asia theater, we assume that you were, and we would get a medical exam and an opinion about the known causes of your condition.
Okay, thank you. My time has expired. I will now recognize Mr. Boss for 5 minutes.
Thank you, Madam Chair. First off, Ms. Carson, Representative Belrakis has a bill, it's House Resolution, or our House 4086. That would require the VA to determine if the presumption of service connection is warranted for disease that may be associated with exposure to burn pits and other airborne hazards. If this bill were already enacted, VA would have to require to make this decision following the September NAS report and any other subsequent related NAS reports. This bill is based on the framework of the Agent Orange Act of 1991. How would the process in this legislation differ from the VA's current process to review the NAS reports and then make recommendations to the Secretary regarding the presumptive conditions?
We'd be more than happy to take that back for our legislative department to respond to that question.
Okay. I really need, I think that's a pretty simple question. So right now, with Agent Orange Act, you're required to make it presumptive, correct?
Under the previous Agent Orange Act, we were. That legislation ended in 2016.
Agent Orange ended in 2016? Okay, all right. Well, all right, let me go to a different question then. Okay, in the past, VA created presumptions without congressional intervention for veterans exposed to contaminated water at Camp Lejeune. Haven't you set a standard that you can do this? And with these particular issues, why is that standard also not being applied?
So we always look at the science and the studies. The Secretary does have the authority, as I previously stated, to determine service connection, which includes a presumption. And in consultation with OMB, we were able to get that regulation through.
Okay, then I'm going to have to, I want to associate myself with Dr. Reese's comments, everything except for the fact that 1979 was a long time ago. But I think the evidence is very clear in science everywhere that exposed to these chemicals and the things being burnt, that they cause particular health hazards. That's why it is that nationally we have bound, in our nation, you're not allowed to do that. Most states have even stricter laws than that. Why is it it's so difficult for us to understand and to get the VA to understand that this is, I understand you want reports, I understand you want that evidence, but we do have that evidence, and we have that evidence over and over and over again. And I feel like we're just studying this and beating a dead horse, and now we have many of our veterans who have been exposed that were not receiving the benefits that will probably do them because we're so busy dancing around with these studies. And it is very, very clear that your mission in the VA is to deal with those who have been exposed and harmed during their time in service. We are continuing down this rat hole where we should be already in the situation that we are taking care of our veterans that have had this exposure. This hearing is vitally important, and unfortunately, the VA keeps coming back with answers of, well, we're not sure. But everybody else in the world is already sure. And I don't see why it's this difficult that we have to keep going over this, and we're not aggressively going after and providing this for those veterans that show signs of problems from this exposure. It's more of a rant than a question. But I just think that the VA needs to know and understand and move forward with the presumption on the burn pits because we don't want to take as long as we did with Agent Orange. With that, I yield back.
Thank you, Mr. Bost. I would now like to recognize Mr. Bilirakis for 5 minutes. I see that you're still logged in, but I don't see you on the screen. Okay. I will now recognize Mr. Cisneros for 5 minutes.
Thank you, Madam Chair. So I really just have one question right now, and that is, if you have an individual that's leaving military service, right? And within that 5-year period, or maybe they're even having problem breathing before they leave active duty service. Once they become a veteran, what is the process for them kind of receiving the treatment and getting the benefits to make sure that they're getting adequate medical attention?
Thank you for that question. We would encourage any veteran who has been treated for a condition during their military service and still experiencing those symptoms to immediately file his or her claim. VBA does have a pre-discharge program that we introduce while a veteran is preparing to discharge 180 days prior to discharge, in which they could actually begin a process of trying to file their claim so that we can give them benefits day after discharge, hopefully for those types of conditions. However, if that condition did not immediately start, but it manifests to a known condition within a 1-year period following service, and that condition can be directly linked to that veteran's period of military service based on the treatment received in service and the condition that they currently have. We have a VBA program called Solid Start, in which we actively engage post-separation with calling veterans and checking to see what conditions they may have, what symptoms they may have that might raise to the level of us encouraging them to invite a claim and to seek health care through VHA. And I'll ask my colleague to speak about any VHA efforts.
With regards to the VHA efforts, thank you. With regards to the VHA efforts, we want the veterans to be cared for in the VA system if at all possible, because it gives us not only better understanding of many of their conditions, not just airborne hazards, but it also gives us an ability to impact their lives positively. And I think VA understands exposures better than other places. I think there are a lot of things VA is better at than the civilian world. I think we are better at PTSD. I think we're better at military environmental exposures. I think we're really good at the overuse injuries, you know, the musculoskeletal things from the service. So I think the biggest thing would be encouraging people to enroll in VA healthcare as soon as they decide that they're going to separate from service, and the day after to enroll.
So even after they get separated and they might be seeking treatment already through the, you know, the DOD, through the military, they still have to apply and opt into the system in order to seek treatment?
They do. They have to apply for benefits to VA as the separate agency, and we work collaboratively with DOD in order to try to do that pre-separation.
Right. So I mean, this is the one thing that is really kind of we need to work on, and we need to make efforts in here, and I think we need to prove this in Congress, right, is there shouldn't have to be a process where one person leaves the DOD, especially if they're seeking treatment, and now they got to apply to get into the treatment over at the VA. It should be a smooth transition and make sure that they can receive simultaneous health care, like while they're going, without having to go or to leave or anything. We need to get to that process to make it a lot easier. And look, the last thing I just have to say is I feel at times, and my father is a Vietnam veteran who receives you know, health care from the VA, you know, because of exposure to Agent Orange, and it did, I will say, he does get good health care there, but the whole process of him going there and trying to get that health care was just a horrible evolution. And it's, at times, it seems like the VA is like the worst insurance company out there, where it's always deny, 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 when we should be saying, okay, you served our country, we need to help you. And with that, I yield back.
Thank you, Mr. Cisneros. And thank you to our witnesses, both here in person and virtually, for participating in the question and answer portion of the hearing. I would like to now take a brief recess while we reset the witness table and welcome our next round of witnesses for the second part of the hearing. Thank you. I would like to call this hearing back to order and introduce our witnesses from the second panel. Joining us today, we have Mr. Shane Learman, Deputy National Legislative Director of the Disabled American Veterans, who joins us in person. Welcome back, Mr. Learman. And secondly, we have from my own district, from Williamsburg, from the nation's second oldest institution of higher learning, from William and Mary's Law School, where they have the Lewis B. Puller Jr. Veterans Benefits Clinic, Mr. Caleb R. Stone, who is a professor of the practice and co-director of the center. So thank you for joining us, Mr. Stone, and welcome to our hearing today. Mr. Learman, I'd like to start with you and recognize you for 5 minutes for an opening statement.
Thank you. Chairman Loria, Ranking Member Boss, and members of the subcommittee. On behalf of DAV's more than 1 million members, we thank you for the opportunity to appear before you today. My remarks will focus on the two main avenues of establishing service connection for conditions related to toxic exposures, presumptive and direct service connection, the recent report from the National Academies, and the concession of exposure. In order to better understand the presumptive process, we first need to know the requirements of direct service connection and the differences with presumptives. To establish direct service connection for a condition, a veteran must meet 3 requirements: a current evidence of a disability, evidence of an in-service event, and 3, medical evidence of a link or an opinion that the current diagnosed condition is at least as likely as not related to the event in service. Presumptive service connection lightens the burden of proof and relieves a veteran of proving one or more of the requirements for direct service connection. In most instances, a veteran cannot prove their specific exposure, whether it's due to poor record keeping by DoD, being unaware of the toxic environment, or just due to the fog of war. The purpose of presumptives is to overcome these gaps of a veteran's specific exposure and the scientific association of those diseases. For example, presumptive service connection for diseases related to Agent Orange requires the veteran to prove the existence of a recognized presumptive disease and proof of service in Vietnam or the waters offshore. The veteran is not required to prove exposure to Agent Orange, as VA concedes the exposure if the veteran was indeed in Vietnam or the waters offshore. However, in many presumptives, it has taken decades to establish presumptive service connection for specific exposures and to associate diseases to those exposures. For example, in 2017, the VA established presumptives for contaminated water at Camp Lejeune, which was over 60 years from the first date of exposure and 30 years from the last date of exposure. The September 11th report from the National Academies, which is 30 years since the first Persian Gulf War and 19 years since 9/11, concluded that there is insufficient data to establish a positive association between exposures and respiratory diseases. It further determined that additional research and different modalities are required. As I noted, it can take decades to establish the required scientific evidence for a positive association. However, this does not preclude a veteran from establishing service connection on a direct basis. According to VA, and as we heard earlier, from June 2007 through May 2020, it adjudicated roughly 13,000 direct service-connected claims for diseases related to burn pit exposure. Nearly 80% of those claims have been denied. Over 50% of the denials, as was noted, were not allowed as there was no evidence of a medical link between their exposure and their disease they were claiming. In part, this is due to not all burn pits claims actually receiving a VA examination and a medical opinion. While we may yet not be able to establish presumptives, we can strengthen the direct service connection process and overcome those barriers by enacting the Veterans Burn Pit Exposure Recognition Act, which has been reported out by the Senate Veterans Affairs Committee and is pending in draft with this subcommittee. It would provide a concession of exposure for veterans who served in countries during periods with active burn pits, which have been confirmed by DoD. And it identifies the actual toxins, chemicals, and airborne hazards to which each veteran would be conceded to have been exposed. It is based on the same accepted list by both DoD and VA and can be updated with future information. If a veteran submits a claim for a disease related to these exposures and VA has insufficient medical evidence to grant, this legislation requires VA to provide an exam with a request for a medical opinion between the disability and the conceded exposure. Madam Chair, to be clear, direct service connection for a disease related to individual exposures is not dependent on whether we have presumptive diseases or that they've been established. Thousands of veterans with life-threatening diseases due to toxic exposures cannot simply wait for presumptives to be established. Congress must take action now and enact the Veterans Burn Pits Exposure Recognition Act. Madam Chair, this concludes my testimony. I would be pleased to answer any questions you or the members may have.
Thank you, Mr. Learman. I'd now like to recognize Mr. Stone, who's joining us virtually for 5 minutes.
Thank you. Chairwoman Luria, Ranking Member Bost, and distinguished subcommittee members. Thank you for inviting me to submit testimony and summarize my written remarks. Congress must take a more active and dictatorial role on burn pits to avoid repeating the mistakes of the past. To provide some examples, Agent Orange was first used in Vietnam in the early 1960s. In response to a 1984 congressional mandate to make Agent Orange rules in the face of accumulating evidence, the VA initially refused to presumptively service connect any condition besides chloracne. A 1986 class action lawsuit, the Bieber case, challenged that restrictive list of presumptive diseases and took 5 entire years to resolve. In 1991, Congress established additional Agent Orange presumptions and required regular federal reports on the health impacts. Still, continued litigation was necessary to fix gaps in VA's coverage. And the presumptive disease list grew slowly. Most recently, ischemic heart disease, Parkinson's, and B-cell leukemia were covered in 2010. In 2019, a federal circuit court decision, later blessed by congressional legislation, granted Blue Water Navy veterans the same presumptions given to those who had stepped foot on Vietnamese soil. That took 50-odd years. Camp Lejeune water contamination first surfaced as a known problem in 1980. If we go back to first exposure, quite a bit earlier than that. But as late as 2010, contrary to accumulated evidence, the Marine Corps asserted that the existing studies had not shown any causal link between Camp Lejeune water contamination and illnesses. Eventually, a 2012 law granted free health care to qualifying veterans suffering from 15 conditions, and it took the VA until 2017 to provide presumptive service connection for just 8 of those diseases. Getting that victory took 37 years after the government first knew about the contaminated water, and if we go back to initial exposure, far, far longer. We are now traveling down the same slow road. We are just at an earlier mile. Veterans with post-9/11 service in Iraq or Afghanistan have filed nearly 250,000 claims related to respiratory illnesses alone. And that last number does not include health problems like cancers, immune-related disorders, or neurological conditions that could be related to burn pit toxins. Without bold action from Congress, we're likely many years away from any sensible resolution on this matter. When I consider that delay, I think of my 88-year-old Marine client with multiple myeloma. If he had not lived until the 2017 Camp Lejeune presumptions were established, he would not have been compensated. I also remember an impoverished Blue Water Navy veteran client of mine who died of diabetes in 2013 while litigating its connection to military service. We were, as the clinic, able to obtain survivor's benefits for his widow 7 years after his death, but only because of this 2019 Blue Water Navy rule change. As for burn pits, I think of an Army veteran client who slept near a burn pit in Afghanistan. He ran ultra marathons before enlisting, but after returning from his deployment, he could not even climb stairs without shortness of breath. His constrictive bronchiolitis forced him to retire from military service, and he's lost a couple of jobs in recent years because of these health challenges. Granted, the VA has rated his condition as totally disabling, but that's because he was diagnosed while still on active duty. If there had been a gap between the manifestation of his symptoms and his discharge, as is frequently the case, he would have needed an extensive litigation system and a private medical opinion linking his condition to military service, likely to win. Otherwise, he would be forced to rely on VA's compensation and pension examinations, provided he could receive them. And those are often rife with problems and hastily completed by third-party contractors. In closing, the compensation system is supposed to be friendly to veterans and give them the benefit of the doubt. I know that the process of deciding what to do is difficult and incredibly complicated. That said, many veterans are frustrated with federal intransigence, believing that these matters are cynically decided with one eye on the mortality tables and the other on the public purse. With swift and aggressive action, sensible, compassionate burn pit legislation that provides presumptive service connection, both healthcare and disability compensation purposes, can offer a powerful counterpoint to that view. Let us avoid the laggard process of the past, because this issue is not going away. Madam Chairwoman, that concludes my testimony. I would be happy to answer any questions.
Thank you, Mr. Stone. We will now move to questions, and I will start by recognizing myself for 5 minutes. Mr. Learman, you've seen that the National Academies of Sciences report, and you know that it doesn't include a list of diseases for us to work off of. What do you think the solution is for creating a responsible compensation scheme with what we know from that report and other science that's being used for the basis of VA determinations?
Well, historically, we've always depended upon, thank you, Madam Chair, we've depended upon the science to guide us on where we go when we establish presumptives. And since we don't have that requirement at this point, or it doesn't appear that we do, we need to find that alternative, and that's why something like the idea of concession of exposure, which would remove some of that burden on veterans now to establish direct service connection, is a way to get it established and do something, right? It's not going to be an automatic grant like a presumptive. It's still going to go through the process, but we've increased the chances of them getting service connection, which, as we know, service connection a lot of time is access to benefits, and it's an access to health care and other things. That's why we really think this is a great way to go, along with, we also believe HR 4137 from Dr. Ruiz is a bill that can do something now in providing health care for them if we can't get that service connection established.
Thank you. And Mr. Stone, thank you again for appearing today to share your experiences in dealing with veterans who are attempting to file these complex claims. Currently, with no concession of exposure and no presumptive disabilities currently recognized related to the airborne hazard exposure in Southwest Asia, what would you say are some of the main obstacles faced by veterans attempting to file claims for disability benefits related to conditions believed to be linked to this type of exposure?
That's a great question. Thank you, Madam Chair. So I would identify two main issues. Lack of records keeping, that could be related to exposure to toxins in the first place, but also any sort of manifestation of symptoms while on active duty military service, and more importantly, any gap between discharge and the manifestation of symptoms. And so if there's a delayed onset in any case, or if there's a delayed onset and the documentation of any symptomology that a veteran may be experiencing, whether it be constrictive bronchiolitis, whether it be other issues that could be related to burn pit exposure, a lack of record keeping and a lack of quickly, implemented records after military service are a serious issue. And that's why I think that you need both the presumption of exposure to the toxins and the presumption that certain diseases are related to that exposure, because I could make hypotheticals all day or talk about instances I've seen with my clients where we did both in order to prevail ultimately. But I think that it's records, and gap between active duty military service and the manifestation of symptoms that are the main problems.
Thank you. And thank you both to our witnesses in the second panel. And I would like to now recognize Mr. Bost for 5 minutes.
Thank you, Madam Chair. Mr. Lerman, can you kind of go into detail why you think it's important for burn pit exposed veterans to receive a disability exam, even if the medical evidence in their veteran C file is not sufficient to grant the claim?
Thank you, Mr. Boss. I appreciate the question. One of the problems veterans face when they file a claim for any service-connected condition is whether or not they're going to get an actual examination. Whether an exam is requested or not is solely at the discretion of the VA. 38 CFR Section 3.159C4 allows a rating specialist to determine if they feel an exam is warranted or not. There are going to be many cases when a veteran files a claim for a condition related to burn pit exposure that VA is going to, in their estimation, assume it's not related and not request an examination. For example, hearing loss. Most of us would automatically assume if a veteran's claiming hearing loss due to burn pits, it's not going to be related and we're not going to provide an examination. However, there is scientific studies out there and research has shown that certain toxic chemicals can cause hearing loss, and those specific chemical groups are found in the list of toxins that the VA already recognizes. So if they're not providing the exam automatically, they are going to miss these types of claims when there is evidence out there of a plausible relationship.
Okay, my second question, in your testimony you discussed how previous presumptions of exposure, such as Agent Orange, have taken Congress decades to establish, and we know we don't want to go down that path. But how can Congress work together with VA, DOD, and stakeholders to ensure that we can have the data about a veteran's potential in-service exposure when they file a claim related to such exposures?
Thank you. That really is a tough question. What can we do to prove or find a way collectively as a group? As we've already heard today, it's hard to track those exposures, right? I know that there was mention of Eilers, which is more going forward. So how do we go back and prove that exposures? And as the Academy's report indicates, that's very difficult for a variety of different reasons. So how do we come up with a way to prove exposures and to find scientific evidence that there's a link? I think there are a variety of things that can be done, and one could be a variety of different committees or commissions with VSO or stakeholder involvement, assisting VA, DOD, and maybe even members of Congress in a committee looking at all of the data and information and help trying to pinpoint diseases and disabilities that should be studied or specific exposures that should be studied. The recent study we're talking about today, the last one was 9 years ago. And the only reason we got to this point is because it was requested again by VA. There was no automatic relook at the condition, which is something else maybe we should consider if we're going to redo a framework for toxic exposures and presumptives. Automatically request those studies every 2 to 5 years, 3 to 5 years. That way we have fresh data to go from every few years and see if there's any additional diseases that are linked.
Thank you. And Mr. Stone, just real quickly, can you please explain your concerns in your testimony that burn pit exposure veterans may need a private medical opinion to have any chance of being awarded their compensation benefits?
Thank you for that question. It's a good question. The reason I bring that up as a concern is there are frequent problems with compensation and pension exams. The VA just has to provide so many on a yearly basis, talking in the millions. And so it is difficult for examiners to spend all the time that is necessary to go through a claim in thorough detail. But if we go back hypothetically and say, let's pretend there's no Agent Orange presumptions for diseases whatsoever, a current CMP examiner might actually use the Agent Orange update in 2012 against a veteran and say there is limited or suggested evidence of an association of, say, prostate cancer, which is on the presumptive list of diseases that are presumptively related to Agent Orange. There would be a lot more discretion or a lot more leeway for doctors to try to come to some sort of logical conclusion, and it's not necessarily accurate that we're going to get a good result in every case and compensate veterans adequately.
Thank you, and my time's expired now. Yield back.
Yes, well, thank you, Mr. Bost, and thank you to Mr. Learman and Mr. Stone for joining us to give remarks and answer some questions in the second panel. I'm going to move into closing statements, and I'd like to say that I'm grateful for the opportunity that we had today to continue to discuss this complicated subject. The testimony provided by our representatives from the VA and from the National Academies of Sciences has been insightful and will be beneficial as we continue to work together towards solutions for our men and women who have honorably served their country in this theater. We focused mostly today on burn pits, but I also just wanted to make a side note that the exposure that we need to examine in this theater is broader than only burn pits. There were a whole host of exposures, things such as dust and sand, particulates, indigenous diseases, depleted uranium, and others, which I expect that we will discuss in depth as we move forward and include those in our discussion as we're looking at all of those things related to service in this theater. I thank Mr. Learman and Mr. Stone for providing perspective and concerns of our veterans on this issue. Your insight into the VBA's adjudication of disability benefits will go a long way towards ensuring this process is accurate and as timely as possible as we progress on this matter. I thank my colleagues for their contributions to today's discussion, especially Dr. Ruiz for taking time to join the committee. And I look forward to working together as we take this information and utilize it to produce results for our veterans. In closing, I'd like to take a brief moment to directly address the men and women who have served in the Middle East and are still serving there today. We hear you, and this subcommittee will continue to prioritize this matter and make sure that we have a system that works for everyone and it allows our veterans, both present and future, to receive the benefits and the health care that they deserve based off of their service. Thank you. And I would like to offer Mr. Bost time to make closing remarks.
Thank you, Madam Chair, and I want to thank all the witnesses for being here with both panels, but I would like to say I'm disappointed in the VA was unable to answer many of our questions here today. You know, this hearing was intended to shed light on the important issue affecting veterans who may have been exposed to toxins or burn pits. I was hoping today's discussion would have helped inform our next steps for establishing a presumptive disability framework for conditions related to burn pits and other toxic exposures. Unfortunately, the VA's inability to engage in a productive dialogue on the next steps prevents us from moving forward at a pace that I believe that the veterans deserve. I want to work with the chair moving forward, and I hope we will have several other of these to try to push forward because we know this issue. We don't want to repeat the past like we did with Agent Orange. We want to get this figured out and actually make sure that those people that deserve these benefits and need these benefits and receive them as quickly as possible. With that, I yield back.
Thank you, Mr. Bost. And with that, we will conclude the hearing. All members are reminded that they have 5 legislative days to revise and extend their remarks and include extraneous materials. And without objection, the subcommittee stands adjourned.